Okay, you should get the little recording disclaimer. And I want to start with just going over the objectives for this class, what we'll be doing, what you can expect. So we're going to start with looking at disorders related to the what we call the accessory glands. When you think of accessories, you think of things that help support something else. You think of your purse and your jewelry, and are what we consider accessories. So our accessory organs, although critical, they help support other organs. That's why they're called accessory organs. So we will have lecture and active learning opportunities this morning with that content. And at the end of that, around 10:20, the full-time faculty will be coming in who have had questions on exam 3 to review that content. Okay, so make sure you stick around and so you can have that exam review time. Okay. All right.
Denise, may I ask you a question? It will be exam review or it will be concept review?
Could you repeat that? I'm turning my volume up. I couldn't hear you, Dimitro. Say it again.
Yeah, it will be exam review or it will be concept review?
It will be what they've been doing. So it'll be content related to the exam.
Okay, thank you.
You're welcome. All right. So we're going to be looking, like I said, at the accessory organs. Those organs include the pancreas. They include the gallbladder. Okay, so we're looking at what's called this exocrine function today. We'll be looking at endocrine function in early December. So one of your last exams that's covered on the final. We'll cover endocrine content. So we're going to be looking at underlying pathophysiology that's responsible for dysfunction within these organs. We'll be applying nursing process, so assessment, intervention, evaluation, diagnosis, right, and revision, always looking back at the effects of your interventions. What type of nursing care is important for patients with these disorders in terms of what diagnostic studies we can expect to see ordered, how we prepare the patient for these diagnostic, and some are both diagnostic and interventional therapies. We'll be talking about pharmacologic and parenteral therapies, so what types of medications would be appropriate to treat these disorders, what types of fluids would be important, and then talk about teaching, right? So we're always teaching. It's one of our primary roles. We're teaching patients all about the disorder, the diagnostic tests, procedures, what to expect. And then once they leave the acute care setting, sending them home, or you might be working in a office environment or community setting, so home care. So teaching is important for all of these environments. All right, so I'm going to minimize that and pull up. I separated all of the, instead of one big long PowerPoint, I separated the different topics. Drag it. All right. So I talked about the purpose of the accessory organs. They help carry out other purposes within the body. And I mentioned that the pancreas is both an exocrine and an endocrine gland. We know that it has cells called islet of Langerhans cells, right? And we know that they produce insulin and the function of insulin in the body. So that's the endocrine function, but there's also an exocrine function. So there are another type of cells in the pancreas called the acinar cells, and acinar cells produce enzymes, and those enzymes are critical. They're responsible for helping break down foodstuffs that we ingest, right? So there's enzymes for breaking down fats, for breaking down starches, and for breaking down proteins. And those enzymes are critical to get those foodstuffs into a form that the body can absorb, so the nutrients can be used and used for nutritional value for the body. Okay, so very important function. These enzymes travel not through the bloodstream like our hormones do, but through what we call glands and ducts. So they're produced within glands, and the pancreas is a gland, and then they travel through ducts. So
I have a question, I'm sorry. Can you spell the name of the exocrine enzymes that are produced? I didn't get that.
So I didn't mention actually what the names of the enzymes are just yet. I have a slide that has that right on it.
I mean the cells that are produced.
Oh, acinar cells. So
Yeah.
acinar cells produce the enzymes. ACINAR.
All right, thank you.
You're welcome. All right. So let's look at the pancreas and all the different organs that are part of this, what we call hepatobiliary system. So we think of hepato meaning liver, right? So you have your liver, you have your ductal system that carries the enzymes, you have your gallbladder, and then you have your pancreas, and then you have your duodenum. So this whole system here is called the enterohepatobiliary system. Okay, I'm gonna make this a little bigger. All right. So when we talk about the pancreas, we see that it has connections through these ductal systems to the liver, the gallbladder, and the duodenum, okay? And your pancreas has three parts. It's got a head, a body, and a tail, okay? And the ducts, there's a duct called the pancreatic duct, or the duct of Warsaw, that travels down the middle of the pancreas. In utero, it's actually two ducts, and then they fuse into the one duct. There can be a disorder where they do not fuse, and it can cause one of the disorders that we're going to talk about in a little bit, acute pancreatitis. So the acinar cells are within the pancreas, and they are going to produce these enzymes, okay? The liver, we know, what does the liver produce that's important for breaking down fats? Can anybody just throw that out there? What?
Bile.
Bile. So the liver produces bile, okay? And bile helps break down, it has several functions, but it helps break down fat. And bile is produced within the hepatocyte, and it goes through the hepatic duct down through the duct. And if we're not eating, we don't need the bile to break down fats. So we have what is a little storage tank for bile, and that is our gallbladder. Okay, so the bile, if you're not eating, there is a sphincter that stays closed way down here at the where the duct for the pancreas and the duodenum meet, called the sphincter of Oddi, and that sphincter stays closed. So the bile, instead of going down to the common bile duct and into the duodenum, where it meets the foodstuffs from the stomach, it's going to be stored in the gallbladder. And your gallbladder is a pear-shaped organ that its purpose is one-fold, and that's to concentrate and store bile. Okay. The duct that connects the gallbladder to the hepatic duct is called the cystic duct. Okay. So it's important to know all the terminology so that you can understand pathophysiology later. Let's say somebody eats. Let's say I had breakfast this morning and I need these enzymes to help start breaking down the food that I ate. Okay, what happens is that sphincter of Oddi is going to open, the gallbladder contracts and pushes the bile that's been hyperconcentrated and stored in the gallbladder, and it pushes it out, and it comes down through the common bile duct, meets other enzymes created by the pancreas, okay? And it's going to start meeting the foods that have gone through the pyloric sphincter into the duodenum, okay? So we know that the food that we eat is already, you know, from the minute it touches our mouth, enzymes start working, right? So it's not just, there's enzymes from when we see and smell food that start working, right? So we have salivary amylase, and that helps start breaking down food in our mouth. It goes down the esophagus. The very acidic concentration of the stomach, which is very high in hydrochloric acid, has a very acidic environment, helps, that's where it starts breaking those foods down, right? Then it gets to the duodenum, okay? So that acidic contents, or chyme is what it's called, goes into the duodenum, and that's where it meets enzymes from the pancreas and then also bile. Okay, bile is going to start giving it that brown color that we know normally is the color of stool, right? So bile is dark and it creates a brown color. All right. What's important about the pancreas, and this is critical that you understand this to really understand your patients with disorders of the pancreas, right? The enzymes, let's talk about those, the enzymes in the pancreas. So there are enzymes that break down starches, okay? Anybody tell me which enzyme breaks down starches?
Amylase.
Amylase, okay? Anybody know what enzyme breaks down fats?
Lipase.
Lipase, good. And then how about the enzyme that breaks down proteins?
Trypsin.
So it's, yeah, protease, trypsin, chymotrypsin gets converted. Yes, so all of those are precursors to protease. So yes, that's correct. So those enzymes are in an inactive form in the pancreas. So they're sitting there ready to work, but they're not breaking anything down yet while they're in the pancreas. Okay, these are potent enzymes. Okay, but they're inactive for a reason, and the reason is because of the neutral environment of the pancreas, and it's neutral because of sodium chloride that's also released in the pancreas. Okay, and sodium bicarbonate, right? So bicarb is a base. It's going to keep those enzymes inactive, right? Once the enzymes travel through the duct of Wirsung, they meet bile coming down from the common bile duct, and they travel through the sphincter of Oddi that's open now that you're eating, and it goes through this, what's called an ampulla of Vater, V-A-T-E-R, which is a little opening. You'll see a little opening right here. The sphincter is like a tire around that opening, that ampulla, okay? And it dumps those enzymes now into this acidic environment where foods come from the stomach. And it's there that those enzymes get activated. okay? Very important to understand that. So the enzymes are in an inactive form in the pancreas. They travel into the duodenum where they become activated by the acidic environment from the stomach. Okay, so there is where they do their job, to start breaking down the foods so that we can use the protein, we can use, the starch and the fats for calories, and we pull the nutrients from those things, and then they travel through the rest of the intestinal system, right? Okay, so that is the whole process of enterohepatic function. Okay, so the liver, the gallbladder, which is the storage place for bile produced by the liver, the pancreas that creates your enzymes that break down starches, fats, and proteins, and the duodenum. Okay. What happens when bile cannot get to the duodenum to help break down fats?
Malabsorption.
It gets reabsorbed into the bloodstream, right? So for whatever reason, we'll talk about the reasons later, but if bile can't get to where it needs to be, it gets reabsorbed into the bloodstream, right? And so then we're going to see some changes related to that. We can see somebody with elevated bilirubin levels, right? And we can see they might have effects of high bilirubin, which we know are jaundice, right? Jaundice skin and jaundice sclera. And what does the stool end up looking like? It's pale, right? It can be more gray colored. So that bile needs to get to the stool. And if it's blocked through that ductal system somewhere, we'll talk about all the reasons for that. It will change where the bile gets absorbed. The bile won't end up in the stool, it ends up in the bloodstream. All right, let's talk about the enzymes. All right, here's that word acinar, the cells that produce it. There are about 1.5 to 2.5 liters, these enzymes per day. So we're talking a lot of enzymes. They're inactive in the pancreas, and then they become activated in the duodenum in that acidic environment. It's sodium bicarb in the pancreas that's excreted by the lining of the ducts that keep them inactive. All right. Proteolytic enzymes. So the inactive form of our proteolytic enzymes is called trypsinogen. When it becomes active in the duodenum, the name changes to trypsin. Okay, so inactive form is trypsinogen, active form is trypsin. Chymotrypsinogen is the inactive form, another proteolytic enzyme that becomes chymotrypsin in an active form. Okay, amylase stays the same, the name doesn't change. It breaks down starches. And then lipase is going to help break down triglycerides into fatty acids and glycerol. So that's how our body uses fats. Okay. So that's what happens when everything's working normally. All right. So we're gonna talk about two disorders of the pancreas: acute pancreatitis and chronic pancreatitis. We'll also talk about pancreatic cancer in a little bit. We're going to go over first acute and chronic pancreatitis, and then we're going to do some active learning strategies. We're going to look at a case study and do some complex questions. Okay. I would like your participation during that time. All right. Acute pancreatitis. How many of you have taken care of patients with acute pancreatitis in the acute care setting this semester or last semester? Good. All right. So we see it a lot actually on the floor that I'm on. See it a lot in the ED. And it's we see it increasingly, as two disorders that lead to acute pancreatitis are pretty prevalent in our society. And one of those things is alcohol abuse or misuse. And the other one is biliary disease. Okay, so gallstones, things that obstruct pancreatic flow. Okay, so acute pancreatitis, there are about 5,000 new cases of acute pancreatitis a year in the US. And it can range from being a very mild disorder to a disorder that can hold a really high morbidity. About 10% of people diagnosed with acute pancreatitis have this severe form of acute pancreatitis. And that's what you as nurses need to watch for in your patient. There are criteria that we look for that can determine how your patient's going to do. Okay, so let's talk first about the mild form. Okay, pancreatitis, itis, we know it's inflammatory condition, right? And so it's a mild, the mild form is what's called edematous or interstitial. So the lining of the pancreas becomes inflamed and swollen. There's increased juices, right? Or enzymes. So mild edematous interstitial, okay? That is the low end of acute pancreatitis. Okay. So what happens during this disorder? The enzymes that we talked about that are in the pancreas and the ducts normally are in an inactive form in the pancreas. What happens is they somehow become activated while in the pancreas instead of in the duodenum. Okay, so those enzymes, your lipase, your amylase, your protease, become active and they start breaking down things when they shouldn't be. So they break down their own tissue. Okay.
Excuse me.
Normally they should be doing that in the duodenum. So mild form, and then there are progressively worsening forms. The most severe form is something called necrotizing hemorrhagic pancreatitis. Okay. So you can imagine what's happening there just by that description. You end up having significant autolysis or breakdown of its own cells, okay? And what happens is that platelet activating factor becomes involved. The necrosis activates enzymes and substrates, including platelet activating factor, and that causes vasodilation and a histamine response that increases vascular permeability. Okay, so you end up with hemorrhage. And we see hemorrhage in a couple places. This is in terms of your assessment, what you want to be watching for with your patient. So they might have what is known as Cullen sign. Okay, so the platelet activating factor gets activated. You end up with vascular dilation and increased permeability, and you end up with retroperitoneal and periumbilical bleeding. Okay, and we see that with these signs. So I always remember Cullen's sign. I think of a C around the umbilicus, so it creates like a C, and that is Cullen's sign. Okay, on the flanks is Turner's sign. Okay, so retroperitoneal bleeding. The prognosis for mild acute pancreatitis is very good. So you give supportive care. What would be examples of, when I say supportive care, can anybody tell me some nursing interventions for supportive care for somebody with the disorder? What does it mean if I support somebody?
IV fluids, maybe?
IV fluids, definitely. So it can be invasive, right? You need an IV in.
Pain management too.
Good. Pain management. Okay. For this patient, if you think about what's happening and what happens when these enzymes are activated, what causes the enzymes to start working, you can think of an intervention that might be considered supportive care for this patient.
Rest on GI, so it's restriction on the food, so the body will come down and enzyme will be not produced.
Right, right. So if I'm a patient and I come in and they diagnose me with acute pancreatitis, when they're bringing trays around and I smell the food going down the hall, or I see food, what happens with those enzymes? They start getting ready to work, right? And that can create significant pain for these patients. So part of supportive care for this patient is to make them NPO, okay? So nothing by mouth, okay? Good. So IV fluids to support hydration.
I have a question.
Mhm. Go ahead.
Sorry, Denise. So in your lecture talked about, so in case you have a patient who is admitted with acute pancreatitis and they're in a lot of pain, and do you treat first the pain and then you put them NPO, or you first you do NPO and then you treat the pain?
Okay, that's a good question, right? We always know pain is like
The vital, yeah.
is a priority, right? But when you think about this question, making them NPO is going to help their pain. If you give them pain medication, but they eat, it's not going to help, right? The pain medication is really not going to do much. Those enzymes are going to start kicking in and working and causing increased increased breakdown of its own tissue, right? So making this person NPO is a high priority, okay? It's going to assist with your pain management. And you'll see these patients when you've taken care of them, right? They know they can't eat anything. And a lot of times, especially if they've been in with this repeatedly, or they have chronic pancreatitis, they do not want food. And oftentimes they're very malnourished because seeing food brings their pain on. Okay, so that's all part of the big picture of acute pancreatitis.
Thank you.
You're welcome. That's a really good question. All right, so a severe form of this holds what we call a high mortality or morbidity, right? There's a certain percent of this population who have a multi-system response to acute pancreatitis. That necrotizing, hemorrhagic, it can affect respiratory system. There's a myocardial depressant factor that's part of this process that decreases their cardiac output. These patients can become very, very acutely ill, have major fluid and electrolyte imbalances, and have septic shock. And that's what leads to their demise, right? So that is something we want to watch for. There have been some criteria that have been developed, we'll talk about in a minute, that give us an idea if our patient's heading down that road, okay? All right, let's talk about the causes. We haven't talked about the causes yet. So you have a patient with acute pancreatitis. We have a tendency to think they must be a drinker, right? Alcohol is one of the main causes. And in the Western world, it is. In the Eastern world, malnutrition is more so. But here in the United States, it is something we want to think about, but we don't want to rule out other things either, okay? Another very common cause of acute pancreatitis is biliary disease, okay? And then these things right here are other causes. Hypertriglycerides. I had a patient in the ED. She was a retired nurse. She came in with acute pancreatitis. She was visiting. She could not believe that she had acute pancreatitis. She said, "I don't drink. I don't think I have gallstones." What she did have was very elevated triglycerides. So we talked about, what she could do to help decrease her triglycerides. Okay, infection can cause, so if you end up with infection that causes dysfunction of the pancreatic cells, it can potentially cause stimulation of the enzymes. There's some genetic disorders that can cause acute pancreatitis. Unknown accounts for 10%. You look at all these things, they have normal triglycerides, they don't drink, they don't have any biliary disease, they haven't had any type of procedures that could lead to acute pancreatitis. So we just can't figure out what the cause is. So that's about 10% of them. The other main cause other than alcohol abuse is obstruction, okay? And obstruction can be caused from a couple of different things. It can be caused from gallstones. So if you have supersaturation of bile salts within the gallbladder, they can form into little stones or big stones, and those stones can block pancreatic enzymes, and they can travel anywhere within the biliary system and can cause blockage. So when things can't get through to where they need to be, you end up with acute pancreatitis. Those enzymes start getting irritated and they get activated and start breaking down in the pancreas. A tumor can be obstructive, right? One of the most common places for tumors in the pancreas are the head of the tumor, which is right where the common bile duct comes down and meets the pancreatic duct before it goes through the ampulla vater into the duodenum. So it can obstruct those ducts. Trauma. So often that's post-procedural trauma. So if you have a endoscope that has been placed down the patient's esophagus, through their stomach, into their duodenum, and now you are probing into these ducts with little devices that attach to this scope, it can cause trauma there, okay? So it can cause, having a procedure can lead to acute pancreatitis. You have to keep all these things in mind. You can have a stenosed sphincter of Oddi. So we know that a sphincter is muscular and it can become stenosed, right? And block flow of these enzymes to get to the duodenum, okay? The ampulla can be blocked. Okay. Sometimes repeated exposure to stones can stenose that sphincter of Oddi. So that sphincter of Oddi, its job is to prevent reflux of bile and all those enzymes that have been activated to get back. It prevents them from going back into the pancreas, okay? Because once they're activated, now they can cause breakdown of its own cell tissue if it goes back through that sphincter. In terms of the infection, you can have bacteria, you can have viruses, you can have parasites. Triglycerides, if they exceed 1,000 milligrams per deciliter, that's when you start seeing problems.
Denise, do we need to know the lab values when you go further? We should.
For those triglyceride levels, it would be helpful to know that.
Thank
you. All right. So how does the patient present? Okay, if you've had a patient with this disease, you know that pain is a huge issue, and that's the primary presenting symptom. And most often it's a sudden onset of a continuous, severe epigastric pain that can radiate to the right shoulder, the right upper quadrant, and it can also radiate to the back. The patient can be nauseous and have been vomiting, and you're already probably thinking, okay, that can definitely lead to fluid and electrolyte imbalances. So you're looking for those things. You're getting an IV in this patient right away because you know you might need to replace these things. You want to give IV medication, so you're thinking IV. Okay, you're thinking a CAT scan to diagnose this, so you want a large bore IV and the AC because they're going to be giving contrast through this IV. Okay. Patient might have decreased bowel sounds, abdominal distension, and rigidity. This is a sign of more severe acute pancreatitis. In fact, it's a sign you want to report to the doctor right away, right? Because it can, that patient may have this hemorrhagic necrotizing pancreatitis form that can cause peritonitis, and you see rigidity in these patients. Symptoms of shock: increased heart rate, decreased blood pressure. Okay, so we're looking for septic shock signs and symptoms, elevated temperature. Okay, so those are things that increase the nurses. Those are red flags. You are working very quickly with this patient to get the IV in, to draw labs, to get the patient the CAT scan, right? This time is really important. And just being aware of what those altered electrolytes can cause. So you're watching for signs related to hypokalemia, hypocalcemia, hypomagnesemia, right? So you're applying all your knowledge from your altered fluid and lights to this patient. All right, so let's look at those criteria. So let's say your patient presents and you think they're in that mild category, okay? So they may, you know, have 8 out of 10 pain, but their vitals are stable. They don't have a fever. There's no Turner's or Cullen sign. Their white blood count's not elevated. And they get that, you think, okay, this is going to be supportive care. We're going to get the IV and fluids. We're going to watch the labs, replace any electrolytes, treat the pain, and monitor this patient. And in a few days, they'll go home. Okay. So let's look at the criteria and why it's important to continue to trend these patients' values, right? Their labs, their vitals. Okay. So upon admission, we're looking at age. Okay. If they are greater than 50 years old, that increases their risk. Okay. Their white blood count level, if it's significantly elevated, serum glucose, serum LDH, so our liver enzymes. Okay. So those things, if those are all elevated upon admission, that's a red flag. Those are criteria that we watch for. If there's only 2 or fewer of those, they would be considered for supportive care. So NPO status, rest of the GI tract, and NG tube might be part of that supportive care. How do you think that might benefit this patient? Why might placing an NG to suction benefit this patient?
So the stomach is not working, kind of.
Right.
The stomach is resting, so that's why would you place the NG tube to ease it?
Exactly. So, you know, that acidic environment, if you're removing everything from the stomach, you decompress the bowel. We know that that rests the bowel. So those enzymes are not going to be working. If your patient has intractable nausea, okay, so let's say they come in, they're nauseous and they're having vomiting, you try Zofran, it doesn't help. You're going to, very likelihood that you might be placing an NG tube dissection. Okay.
Would you need a doctor's order for that?
Yes.
You would, right? You would
Yes.
consult with the doctor. Okay.
Yeah, you need to order for the IV, for the NG, for the fluids. We receive orders for all of those things. Am I going to wait to put the IV in for that doctor to come in and see that patient? No. So we have standards of protocol that we do based on a diagnosis. So we'd also get a 12 lead EKG on this patient, right? Because if they're having epigastric pain, could that be cardiac? It could.
Yes.
Yes.
So 12 lead EKG, right? So if there are 2 or fewer of these on admission, supportive care. So let's say they're 60 years old and they have an elevated glucose level. Okay, so they don't have any other of the criteria. Okay, if they have 3 to 4, it increases the morbidity rate to about 15%. Let's look at these other criteria. And these can develop 48 hours after admission. And that's why it's important to trend these values and watch them. So we talk about trending values and the importance of using clinical reasoning and clinical judgment. This is a really good example of that. So you're watching, knowing that this patient, even though they've been in the hospital with supportive care for a couple of days, it could still deteriorate. And they could become that percentage of patients with necrotizing hemorrhagic pancreatitis that holds a high morbidity. If their hematocrit falls greater than 10 percentage points, if their BUN elevates greater than 5 milligrams per deciliter, if their serum calcium falls to less than 8, their PaO2, they start having respiratory symptoms and you draw gases and you find that they're hypoxic, right? The PaO2 is less than 60 milligrams of mercury. Or they start retaining fluid, okay? So you see a fluid retention. All right, if they hold 5 to 6 of these criteria, that increases the mortality rate to 40%. And then 7 or greater, even higher, okay? So the more criteria you have, the higher the more mortality, okay? So you wanna make sure that your patient is stable and is showing improvements in any of these values, right? So on X-ray or CAT scan, if you're doing a chest CT, but most often they don't just do the chest, they do an abdominal CT and a chest X-ray, you can see a patient with pleural effusions or a pneumonia. And that can be as a result of that platelet activating factor and histamine response and vascular vasodilation that occurs as a result of that necrosis that's occurring. Okay, so those are all stimulated by the process of necrosis and infection and cell death. Okay, that myocardial depressant factor I mentioned, and that is actually released by the pancreas. It's pretty interesting. So the pancreas itself releases it's a substrate called myocardial depressant factor, which decreases contractility, cardiac output, and perfusion pressures. So that decreases flow to the pancreas and causes ischemia and can lead to a necrotic pancreas. So these patients would end up, if they have that necrotizing hemorrhagic pancreatitis, you're going to see them transferred from the floor to the ICU, right? Or they might go right to the ICU from the ED. Because knowing these criteria, we know that patient can hold a high mortality. So they're going to be treated with volume replacement and vasopressors, so medications that are going to counteract that vasodilatory effect that's going on in the body from necrosis. And it's going to vasoconstrict and clamp down on those vessels. So you can have, your body has something to work with in terms of volume. Okay. So contractility agents. So our vasopressors, you could use dobutamine or dopamine at higher doses. Epinephrine, right? So those are our potent vasoconstrictors. So epi-drip. So these would be continuous infusions of these medications. So these are those meds that you're calculating mics per kilogram per minute. We're going to look at the labs, right? So I mentioned the white blood count, but we're looking at those enzyme levels. And this is really the clincher, in addition to the CAT scan, for diagnosing acute pancreatitis, right? So, and specifically, there's one enzyme that's only produced by the pancreas, and that is your lipase level. Okay, so you really want to hone in on what that lipase level is. Okay, and we can see some pretty high lipase levels. So lipase is released into the bloodstream when damage occurs to those acinar cells. We can see it elevated with acute and chronic pancreatitis and with pancreatic cancer. Bilirubin. Bilirubin is going to give us an idea of the cause, right? If my bilirubin is elevated, what could be the cause when you think about the causes we talked about?
An obstruction.
Obstruction related to biliary disease, good. Or a tumor, good. So not just, it's obstruction in general. That's right, Emily. Calcium's decreased, can be decreased in acute and in acute pancreatitis as well as chronic alcohol abuse. So the cause is unknown. You might see that Chopstick sign, Trousseau's sign, numbness in the fingers and lips, muscle twitching, right? So when we pump up the cuff on their arm, you see a twitching, or if you strike the side of their cheek, you can see a twitching there, okay? Chopstick and Trousseau's sign. The alkaline phosphatase is an enzyme found in cells that line the biliary tract and can be increased in biliary obstruction. So another lab that points us to a cause. The CAT scan, you want to look that up and you want to see the result. Okay, it will tell you if there's just edematous interstitial edema, or it'll tell you if you've got a necrotic pancreas. Okay, so you want to look at that CAT scan result.
Hey, Denise,
Mm-hmm.
could you please repeat what you said about the alkaline phosphatase, that it lines the
It lines
biliary tract?
it lines the biliary tract and is it's increased with biliary obstruction.
Okay. That's
So
what
it points you to biliary disease as a cause versus alcoholism or high triglycerides. All right. So management, make that patient NPO, okay? And that's maintaining pancreatic rest. So we're resting the pancreas, we're resting the GI tract by making the patient NPO. They might require an NG2 if unretractable nausea. Relieve the pain, okay? how do we relieve the pain? So a couple things are going to help with pain control. We can put the patient in certain positions. The patient may assume a certain position. When you lie this patient supine and flat, they have worsening pain. So they're going to be wanting to sit up in at least a semi-Fowler's position. You might see them in a fetal position. Okay, that's position is helpful, but it's not going to completely help, right? So this pain is a sudden onset and it's continuous. It's going to require analgesics. Okay, it can, another medications you might see ordered are antispasmodics such as Bentyl. And let's talk a bit about analgesics. Depending on the cause, there are some analgesics that might be contraindicated. And this is something that the nurse should know. You should learn this in school and remember this for down the line. Morphine can cause spasm of the sphincter of Oddi. Okay, so if there's an issue with pancreatic enzymes, with acute pancreatitis, you're not going to see that as the narcotic of choice. Okay. In fact, they give morphine in tests and procedures where they want to assess the function of the sphincter of Oddi. So the last thing you want to do is give morphine at this point. So you're going to see other opioid analgesics such as Dilaudid, hydromorphone, okay, given for these patients. If you give this patient Tylenol or ibuprofen, which you would definitely not want to give, right? Because especially if potentially they could have hemorrhagic issues, right? We don't want to give a non-steroidal anti-inflammatory with somebody with potential for bleeding. Okay. So you might find a doctor try to give a Firamev to this patient without maybe it'll help a little bit, but it typically requires your big guns in terms of narcotic analgesic.
So you said they'll give hydromorphine? I'm sorry.
Mhm.
Okay. But not morphine because it's contraindicated?
Correct.
Okay.
Sorry, Denise, you were breaking up for me during that slide on so you said no NSAIDs, no Tylenol, ibuprofen, or morphine,
Yeah.
but give
You might see them try Tylenol, but it typically requires an opioid analgesic. So your big guns for pain relief. So we're talking severe pain. It can be a boring, you'll see these patients come in and report greater than 10 out of 10 pain. They're just in agony. Okay, antispasmodics like Bentyl and acids may be helpful. You're going to see these patients on your medications like your IV protonics. Okay, and these are going to be all IV forms initially, right? Because you're not giving anything PO. Your IV Zofran. Fibrin acid derivatives. Which diagnosis would that medication be helpful for? Which diagnosis relating to the cause could a fibrin acid derivative help?
High
Triglycerides. Somebody said that. That's right. Okay. Antibiotics, right? So that would be appropriate to give an antibiotic to either treat somebody with a necrotizing pancreatitis or to prevent it. Okay. And then you're going to be given fluids. You might be given LR to this patient, right? Because of the need for electrolytes. But most often they're going to be chasing the electrolytes with specific orders for calcium and potassium and magnesium. If the patient comes in because of alcohol-related acute pancreatitis, most often they're malnourished to begin with, right? Because their calories might be more so liquid than nutritionally dense. So you're going to see LR given, and you're going to be looking at albumin level to assess the nutritional status, right? So that's going to represent how severely malnourished this patient is, along with your physical assessment. What do you see?
You see weight loss?
Yeah, yeah. And why, when you think about weight loss, if this patient comes in with repeated bouts, and we do see this, and it is specifically for alcohol-related acute pancreatitis, the patient just cannot stop drinking. They continue to drink, and they end up with tissue that becomes non-functional, right? You get tissue that is it's not working, right? So in those patients, you have to think about a whole other many things, okay? So if you were, let's say you get through the acute phase, but this patient needs nutritional support, what might be some options for this patient in terms of nutrition? How do we give nutrition to somebody who can't eat because they're NPO?
TPN?
Yeah.
So TPN might be appropriate, and it may be with or without the lipids, depending on the needs of the patient. Most often they do need the lipids, right, for the caloric piece of that. But you can also do what's called an enteral feeding. So we talk about G tubes, gastric tubes, and G tubes that end in the stomach. But if you bypass the stomach and feed the jejunum, that can be a solution, right? So you can place a J tube, and we see patients, it's a smaller tube. When I was working in ICU, we used this Corpac tube that we would place, and it would, we'd put the patient on their side. We would give them metoclopramide to increase peristalsis. We'd place the tube, and then we'd get a KUB x-ray to see if that tip of that tube resided in the duodenum or the jejunum, which is where we wanted it to end up. So not a gastric tube, but a J tube, okay? Because that way you can still feed the gut without having all those enzymes coming into the duodenum. They're not activated if you go distal. Does that make sense? Okay.
So is that so the stomach is at rest? You mean
The
that's
stomach
why
stays at rest. So that's the benefit of these J tubes. And have you seen these on the floor? These smaller tubes that can
No.
clot real easy with medication administration, right? And they're more pliable. There's a little weighted tip on the end of those that's filled with mercury, and it keeps the tube in place in the jejunum. Okay. So you're going to feed, you can do what's called not gastric feeding, but enteral feeding. You're feeding the intestine or the gut.
Can I ask a question? But having that in the intestines isn't going to stimulate the enzyme.
You're distal to the stomach.
Okay.
Okay. It might somewhat affect absorption, but they're, depending on your tube feeding, it's hopefully they're going to get absorption. All right, let's talk about absorption, because what can happen with patients with pancreatitis and with other exocrine disorders, such as that affects exocrine disorders such as pancreatic cancer, cystic fibrosis. We're going to talk about that in a little bit. That affects exocrine function, okay? Because the ducts get filled with that mucolytic mucus, and the enzymes can't get through. It's like swimming against going through a thick, waxy substance, right? So we have what's called malabsorption. I have a video that talks about that. It's really important that you guys understand the concept of malabsorption. So I'm going to pull that up. They're going to talk about supplementing the enzymes. So if your body doesn't can't produce the enzymes, you can give them synthetically. Okay, so if you've had destruction of those eosinophil cells and they're not making the enzymes, you can take synthetic. Just like you can take synthetic hormones, you can take insulin, you can take vasopressin for for different hormones. You can take synthetic lipase, this has all three: amylase, lipase, and protease. Okay, so let's watch this. Let me know if you can't hear it right away, okay?
When the pancreas is healthy, it produces enzymes to help break down food and secretes them into the small intestine. There are different enzymes to digest carbohydrates, proteins, and fats. If you have pancreatic exocrine insufficiency, then your pancreas doesn't make enough enzymes to break down all the food you eat into absorbable components. Pancreatic exocrine insufficiency is a condition that occurs as a complication of pancreatic damage. The most common causes of pancreatic exocrine insufficiency are chronic pancreatitis, alcohol abuse, pancreatic cancer, type 1 diabetes, genetic disorders such as cystic fibrosis, inflammation from digestive diseases such as Crohn's disease or celiac disease, and complications from some surgeries in the digestive tract. Most pancreatic exocrine insufficiency symptoms result from not absorbing enough nutrition from food. Too much unabsorbed fat in the intestine causes stools that are oily, large, pale, very foul-smelling, and tend to float in toilet water and stay in the toilet bowl even after flushing. This is known as steatorrhea. Fatty stools can also lead to fecal incontinence or oily leakage, intestinal gas, and bloating. Nutritional deficiencies are common, especially of the fat-soluble vitamins A, D, E, and K. Pancreatic exocrine insufficiency can also cause weight loss. In children, these factors can result in a failure to thrive. Some symptoms of nutrient malabsorption include fatigue from not enough calories or various nutritional deficiencies, anemia from vitamin B12 or iron deficiency, bone disease from vitamin D deficiency, and bleeding disorders from vitamin K deficiency. When it comes to treating pancreatic exocrine insufficiency, the first and most important step is to identify and manage the underlying cause. These treatments will vary. However, there are options available to treat the symptoms of pancreatic exocrine insufficiency itself. Eat multiple small meals rather than 1 or 2 large meals. Fatty foods can worsen steatorrhea, but it is still important to consume some fats because you need them to absorb certain vitamins. Just stick to healthy sources such as nuts, seeds, olives, or fatty fish, rather than processed foods or red meat. And while fiber is good for gut health, many individuals with pancreatic exocrine insufficiency find low fiber intake makes digestion easier. You might also need certain vitamin or mineral supplements, and it's a good idea to discuss any nutrition concerns with a registered dietitian. The most effective treatment for pancreatic exocrine insufficiency is pancreatic enzyme replacement therapy, which involves taking a medication called pancreolipase, sold under various brand names, which provide the body with enzymes. You can take pancreolipase with each meal or snack that contains fat and/or protein. You will need to work with your healthcare team to establish dosage for pancreolipase, as this will vary from person to person and meal to meal, with large fatty meals requiring more enzymes than small, low-fat meals. With pancreatic enzyme replacement therapy and some dietary adjustments, you can manage symptoms of pancreatic exocrine insufficiency. However, you still need to work with your healthcare team to treat the underlying cause of pancreatic exocrine insufficiency as best you can. To learn more about pancreatic
Okay. So if you have chronic effects and actually affects the amount of pancreatic enzymes that are produced by the pancreas, that's when these pancreatic enzymes are required. Okay, you see patients keep these at their bedside because it's important that they take it with the first bite of food, right? So once they start eating, so you know, they've rested the gut, they're not having pain, the pain resides and resolves. So now you can start with clear liquids and increase as tolerated. But these patients, like I said, you're not, if those chronic changes now affect the amount of enzymes that are going to be produced. So they might require synthetic forms of the enzyme. Okay. So malabsorption, you can tell if somebody's absorbing their foods by looking at their stool. And like how they said, if they're oily and fatty and float at the top of the toilet bowl, that's a sign of malabsorption, right? They're not breaking down the foodstuffs, and therefore they're not absorbing what needs to be absorbed from the food. Okay, with kids with cystic fibrosis, you see their bellies get really, really big because of malabsorption. So they have voracious appetites. They'll eat all the time, right? Because they're not getting their caloric requirements. So the food just goes right through, unabsorbed, and you see, you know, fat globules and things in their food. So and they can have something called dumping syndrome as well, where they might, things just go right through them really, really quick. So they have to go suddenly, and then they have just a very large fatty stools. So those are things we want to watch for. We want to look at the stool to make sure it looks normal, and that's how we know that they're absorbing their nutrients by looking at their stool. Okay. All right. Okay. So for patients with acute pancreatitis, they might require procedures. They might require surgical intervention for, they might use a procedure to diagnose acute pancreatitis, give them more information, to look and see the cause of acute pancreatitis. Is there a tumor? Are there stones in the ducts? They can use ultrasound as well for that. They can establish drainage if you have a necrotic infected pancreas. You can establish drainage through a T-tube or what's something called a C-tube that will allow for drainage and irrigation of a necrotic wound. They can resect and debride. So these procedures can be indicated for a number of reasons. You can even do an exploratory laparotomy to assist in that diagnosis. But then there's other reasons as well. So these patients might have multiple drains in place post-op, as well as a surgical incision. The incision can be left open for irrigation and repacking, depending on the amount of necrosis, right? They don't want to close up the incision if they don't feel confident that the infection has been fully addressed. So there are complications, of course, anytime you do a procedure, whether it's a scope or laparoscope, and endoscope or a laparoscope. There's always that risk of causing inflammation, right? And inflammation can cause obstruction, and then obstruction can lead to worsening symptoms, right? You can have peritonitis. That's a really bad complication that you want to avoid, but you're going to be assessing for that, right? So rigid abdomen, rebound tenderness. Patients will jump through the roof when you press on their abdomen. You can have fistula formation, so opening between two areas that aren't commonly open, right? So between the pancreas and the duodenum, the stomach and the pancreas, so fistulas. All right. I have a video on a Whipple procedure that goes over all of these pre-op and post-operative nursing management. It does a really good job, so I'm going to show you that in a little bit. Okay, so we want to look at this patient here. This patient has acute pancreatitis, so they've determined that based on CAT scan and based on labs, okay? And they're on day 3 of hospitalization, okay? They're currently on your med-surg floor, and they're receiving fluids and analgesics, so they continue to have pain. They're getting supportive care with IV fluids and pain medication. Patient's 59. Is this one of the criteria?
Yes.
Okay, so they have one criteria. Their white blood count is elevated. Is that a criteria?
Yes.
Okay, that's 2. Their serum calcium is at 7.6. Is that low or normal or high?
Low.
That's low, so that's another criteria. So we've already reached several of these criteria, okay? So less than 8. The LDH and the AST, so your liver enzymes are elevated. The hematocrit has decreased gradually on admission from 35% to 23% on day 3 of hospitalization. Okay, is that a criteria?
Yes.
Okay, so hematocrit falls greater than 10. Okay, so you're trending these and you're watching them. The patients showing signs of shortness of breath, decreased O2 saturations, blood gases are done, and they have been found to have a PaO2 of 45. Is that a criteria?
Yeah.
Okay, so we're like piling up the criteria here. All right, and these are the vitals right now. The BUN is also low. Their pressure, it doesn't give us the baseline, but we see that their blood pressure is 108 over 64. Heart rate of 111, it's regular. Respiratory rate of 28 and a 99.8 temp with a 7 out of 10 pain level, okay? So based on these criteria, would you be concerned for this patient?
Yes.
Yes, good. So you would be concerned. So you want to think about if you were to call this patient, call the provider, how might you present this patient using SBAR? Would anybody in the class like to do that for me? So we have our SBAR criteria, right? We have situation, background, assessment, and recommendation, okay? So for situation, who would like to do the situation?
I can try.
Awesome, thank you.
So patient represents currently with
So
acute.
first of all, you're going to identify yourself, right?
Oh, that's right. I forgot. All right. My name is Maya, and I'm the nurse caring for this patient today. Patient name is Jacqueline. She's 59 years old, and she represents. She is day 3 of hospitalization. She's currently admitted to the med-surg floor. representing with a diagnosis of acute pancreatitis, and as of right now, she's receiving fluids and analgesics. Anything else? I don't know. Should I say?
Okay, so that's the situation. That's good. You did a really good job.
Thanks.
Okay, so the person you're calling, let's say, you know, they've had a hospitalist for the first 2 days, but the third day that hospitalist is off and there's a new hospitalist. So you did a really good job of describing, you know, information for a provider who might not know this patient well yet, right? Okay, so that's the situation, and gave some of the background as well. All right, so would anyone like to, based on what the information we have here, what are you going to talk about as far as your assessment?
Probably like what the lab values are at this
Yeah,
point, like her
definitely.
most recent lab values show, and then read them off.
So what would be the 2 that you would hone in on based on, actually 3? They're all somewhat important, but 3 that are more critical.
Hematocrit,
Yeah.
yeah, and white blood cells.
PO2.
The
And, yeah,
PaO2,
PaO2.
definitely. And the one other one that's big.
Her respiratory rate is very high.
It's
Mhm.
the LDH. The liver enzymes are high.
Okay, something even I would want to say like pretty quickly when I'm
Their glucose level?
Glucose.
nope.
Calcium.
Calcium. Why is calcium so important?
Seizures?
Could it affect your heart?
What happens when your calcium's low?
Hypocalcemia. She's a risk of hypocalcemia. So the muscle spasm and the Trousseau sign. So you want to address that right away.
Can it cause laryngospasm?
Yeah.
Can that your breathing? Would
Yes.
that be a medical emergency? Yeah.
Yes.
So we'll talk about calcium a lot when we talk about endocrine. But hypocalcemia, if you have, you know, a drop and that calcium level starts going, you're going to see muscle twitching. The patient is at risk for laryngospasm. And in fact, for patients who have thyroid surgery, there's little parathyroid glands embedded in your thyroid, and those parathyroid glands, if they're damaged when your thyroid surgery is done, if the thyroid's removed and you accidentally damage or remove parathyroid tissue with that, our parathyroid is responsible for regulating calcium and phosphorus, right? That's what it does. That's its whole purpose. So they actually keep a trach set at the bedside of these patients, okay? Because if their calcium level drops suddenly, it can cause laryngospasm, okay? So calcium is a really important electrolyte to replace right away, okay? So you're going to anticipate orders. So, and you can actually make recommendations. So if they don't say, okay, let's replace the calcium, I want you to give this, you're going to say, would you like calcium replacement for this patient? So you can advocate and communicate for your patient here. Okay. So good.
Can we be concerned about a septic shock? Because the patient have high temperature with elevated white blood cells.
Yeah.
And also with this change in his blood, he at risk for DIC too.
Yeah, right. So you're looking for those 2 signs, that retroperitoneal and periumbilical bleeding. So part of your assessment when you have patients with acute pancreatitis is really looking for these signs. Okay, so all these things are really important. All right, so there's something called, when we are talking and communicating to a doctor or a nurse practitioner who's caring for the patient, it's so important that we communicate everything. That's important. Okay, so, and you can also make recommendations. If this patient's not doing well and you want them to come see the patient, they may say, oh, I'll be down in a couple of minutes. So, you know, they're coming. But if they don't, say, when the patient's not looking good, it would be great if you could, you know, come see the patient. So make sure that you, and depending on how critical they look, you're going to be more persistent, right? So you're advocating for the patient, okay? You are thinking about outcomes, right? So everything is about outcomes. If they give you a verbal order for something over the phone, so now we've got these wonderful systems, electronic records. We don't really take phone records anymore. They can pull up the patient's orders and put them in right then and there. So this doesn't happen very often. It does happen in the ER still. It might happen in the OR, depending on where you're working. But most of the time, those orders are going in electronically right away, okay? But if you receive an order. So if I have a patient in ED and they're going to the OR and I get a call from the orthopedist or the surgical resident and they say, okay, we need to replace this calcium. And then they don't put it in, right? So one, I need to be calling them back and saying, you need to, you know, put these orders in. But we want to do something called callback. Okay, so I have a video here that I'm gonna pull up. It's quick and gets right to the point. And I can tell you a couple things with callbacks, with repeating back. Get the name of the person you're talking to. If you forget the name, you can't put in your note who you got the order from, and that's important. You don't want just received order from MD. You want to say who the doctor is or the nurse practitioner, right? And repeat it back, because you can be off by the route, or maybe they don't say the route. They assume you know the route, but you know, just make sure you repeat it back.
1 gram of calcium gluconate diluted in 100 milliliters of normal saline IV for an hour.
Confirm that. 1
gram of calcium gluconate diluted in 100 milliliters of normal saline IV for an hour.
Confirm that. 1 gram calcium gluconate diluted in 100 milliliters of normal saline IV over an hour?
Correct.
All right, so that's as quick and easy as it is. So it's very simple. And I do have to tell you that they don't tell you what to give it in and how quick to give it, right? You have to look that up. I have never ever had somebody say, give it over an hour and put it in 100 mLs of normal saline, right? They don't tell you that, right? They say, I want a gram of calcium gluconate IV, okay? So you make sure that the order's put in and that you've done your 3-5 right checks before you administer it and you've seen the lab value yourself, okay? You don't, and they should look up this lab value themselves. They might, you know, you might be on your 11th hour of a 12-hour shift overnight and you looked at the wrong time when you were looking at that order. So you're making sure you have things pulled up. So before I get on the phone with somebody, I am at a phone near a computer. I pull the patient up. I have the labs in front of me, because 9 times out of 10, they're going to ask you something else that you're going to need to look up. So you want to have that open and ready. Okay. So you want to be organized, and because everybody's time is important. Okay. So you repeat it back and then you look it up to determine, you know, what are you going to dilute it in and how fast are you going to give it, and make sure that it's, we talked about this in clinical last week, the importance of making sure that you're using the right dilution for your unit. So if you're in the ICU working versus on the floor, or the OR, or where you have advanced monitoring. You can give things in a greater concentration. For example, potassium. You can give it in a greater concentration through a central line in the unit with monitoring, hemodynamic monitoring. So know the standards of practice for your unit, okay? If you can give it anywhere, any nurse can give it, it'll say RN may give, and that just means any RN anywhere can give it. Okay, that's on your policies on your drug monographs for your facility. Okay, so make sure you're aware of all of those things. Okay, any questions about that? Good job with the S-bar. Hopefully you're all using S-bar when you're communicating to anybody, whether it's the nurse, the case manager, the prescriber. Okay, so keep that in mind. And so good. Okay, let's talk a little bit about, okay, actually what we're going to do next is we're going to look at I'm gonna do a poll. Okay, I think I have to stop sharing. We're gonna do a couple acute pancreatitis NCLEX questions, okay? Here's my polls. Okay, so I am going to open this poll and let's see. I trialed it, that's why there's an existing poll. So. Okay, so go ahead and take that and we'll end it in about, there's 4 questions, so we'll end it in 4 minutes.
So the first one is more than one answer because it's letting us pick more than one. So I'm
sorry. Yeah, just pick one.
Okay.
Did you say it was 4 questions?
Is it just 3? Sorry.
Yeah, I only have 3.
Okay, yeah. Sorry, just 3 then.
And the third one is like, it says potential causes and it's like all of them.
Okay. Is it all of them?
Yeah, it doesn't say select all though. It just says multiple choice.
Yeah. I mean, I don't know if it's all of them, but it's at least more. It's more than one.
Yeah, there is more than one for that one. That's the only one that is more than one. Just give you about 30 more seconds. Okay, so I'm going to end the polling and we're going to look at the results. Can you guys see the results?
Yeah, we can.
Okay. All right, so let's look at the first one. The nurse would expect what type of nutrition order for a patient recently admitted with acute pancreatitis. Okay, so you're not given NPO for this. So this is a patient who has been recently admitted. So once they are able to eat, this would be an appropriate type of nutrition order for them. All right, so we have the choices of PPN, TPN, oral nutrition, and enteral nutrition. Okay, so the majority of you, 67%, did say TPN. Okay, and we did talk about TPN, but I just want to reinforce a couple things about TPN and about nutrition. When we try to determine the type of nutrition that's appropriate for the patient, TPN is really it's a possibility, but it's a last resort. We want to feed the gut as a priority versus giving IV nutrition. We want to keep the gut working if at all possible. So because of that, I would choose enteral nutrition. Okay, so the patient's been recently admitted. You're not going to feed the stomach just yet, but if you had these choices, NPO status is not there, you would choose enteral nutrition over TPN. So if you think back to your lectures on nutrition, you hopefully remember that feeding the gut is always first. Okay, so you're not going to do gastric feedings. You're doing enteral feedings. Okay.
Isn't an enteral feeding going to be more invasive though? Don't you have to have it surgically put in?
No. So you can place like that tube that I mentioned. It's a smaller tube.
Okay.
They're called Dobhoff's core packs. So they're placed just like an NG, but they're smaller and they have a little weighted tip. And you'd place them exactly the same procedure as you would an NG, but it just goes further and you verify them with the KUB to make sure they're in the intestine. Okay.
So I have a question for you, Denise.
Sure.
It does, I'm just confused because it does say on your slide for acute pancreatitis medical management, TPN.
Yeah.
I know we talked about both.
Yeah.
But
TPN would be somebody, this one's just admitted. This would be, you're not going to see TPN really started on somebody with an acute issue. You're going to wait for TPN. You're going to see TPN ordered later. Okay. But if you have to address nutrition, you're going to always feed the gut first. Okay. So it is important to feed the gut first if possible. And then if this patient has progressed to chronic pancreatitis where they're not producing any enzymes, TPN would be indicated for them. But always feed the gut first. And TPN for somebody that's going to have long-term lack of nutrition. So this patient, after their, the supportive care, the antibiotics, resting the gut, the goal is to feed them again as soon as possible. This oral, nutrition through the GI tract is always optimal over parenteral. And parenteral has actually a lot more complications than enteral nutrition, right? You have to give it through a central line, right? And there's all the complications associated with central lines. So enteral nutrition would be appropriate. All right, so let's look at number 2. Nursing interventions for the patient during an episode of acute pancreatitis should include, so the morphine, a couple of you chose the morphine, and we talked about how morphine wouldn't be an appropriate, like hydromorphone or another opioid analgesic. Demerol would be another option. Meperidine is the generic or the official name for Demerol, but morphine causes spasm of the sphincter of Oddi, so we would not want to use the morphine. You're going to make the patient NPO, so that would be, so 93% of you did put that. Caffeine is not pertinent to this question, and then a heating pad. If they've got especially if they've got that retroperitoneal or periumbilical bleeding related to necrotizing, heat is not going to be indicated, and heat's not going to help the pain, right? It's this pain is way beyond heat, like musculoskeletal type pain. All right, the last one. Which of the following are potential causes of acute pancreatitis? So we've talked about many of these. We know elevated triglycerides can be. Biliary obstruction is one of the common causes. Alcohol abuse is a common cause. The diet high in red meat. So diet high in red meat can be a cause of pancreatic cancer. It's considered one of the risk factors for pancreatic cancer, but not necessarily for acute pancreatitis. Okay, so acute pancreatitis, you know, a tumor can be a cause of acute pancreatitis, but now you're making like inferences. Okay, so the diet high in red meat is not considered a potential cause of acute pancreatitis. It's a potential cause of pancreatic cancer.
I have a question.
Yes.
Isn't a diet high in red meat a cause of hypertriglyceridemia?
No. What kinds of things? I mean, if you've got really fatty red meat versus lean red meat, but
okay.
You don't read into the question. You're going to go specifically.
Okay.
Yeah. Okay. So things like processed foods, fatty foods would be appropriate. Okay. Awesome. Cute little kids there.
Denise, can I ask a question following up on that last question? So you said diets high in fat and things. If it said high fats and that was a cause of triglyceride, would we make that leap or just leave the diet high in fat out because we're talking specific causes, which is the hypertriglyceridemia?
You know, if there's talking about specific causes, the way that's worded, I would want to look for, you know, for hypertriglyceridemia, for biliary disease, for alcohol misuse, idiopathic, pancreatic tumor.
We would not choose the diet high in fat. We'd leave that out if it was an NCLEX question that specifically asked for causes, the way that was worded.
You know, that's kind of going back and forth a little bit in my head with that, but you know, I pulled that from a NCLEX review book, that specific question. So based on that, I would say yes to your question.
Okay, thank you.
All right, so I'm going to share my screen again. Yes.
Denise, I want to just say thank you for this rationale. That's what we actually missing in our previous lecture, and that's what we're missing from our exam when we have a question and then when it's all rationale explained, not like basic concept. Thank you.
You're welcome. Yeah, remediation of any questions that you do when you guys are in Prep U. that remediation piece is critical. And as you're studying for the NCLEX, and after May, you guys are all going to be studying for that NCLEX, you want to remediate all your questions that you don't, it's an important piece. So, all right. So I mentioned the causes of chronic pancreatitis. Alcohol abuse, protein trace elements, untreated hyperparathyroidism is a possible cause, congenital anomalies, pancreatic trauma. Okay, so the big thing when we see chronic pancreatitis, it is not uncommon for you to think, and it would be appropriate for you to think alcohol abuse, because that does account for most of the causes in this country. So there's this questionnaire. So these patients that come in, you do want to screen them and for alcohol use or misuse. Okay, so there's this CAGE questionnaire. My primary doctor started doing this in the office several years back, and it has a very high specificity for identifying those at risk for drinking. If there's yes to 2 or more of these questions, it indicates alcohol abuse. So it holds a 76% sensitivity and a 94% specificity. So the percent correctly identified as not having. So this sensitivity is percent of people correctly identified as having. So it's not 100% accurate, but it's pretty close. So even if there's one yes to one of these questions, it merits further inquiry. Has anybody been given one of these in your primary doctor visits?
Yeah.
Have you heard of this? Okay, so this is called the CAGE questionnaire. Okay, have you ever had the need to cut back? Are people getting annoyed or criticize you about your drinking? Have you ever felt guilty about your drinking, or have you ever started the day with an alcoholic drink? So any of those yeses, you should consider, thinking about your drinking, how much you drink. So, and then if they are a drinker, you're going to go further, and you're going to do something we call an audit C, where you now determine, how much the patient's drinking, and if they're going to need a protocol for preventing alcohol withdrawal. Okay, because we know that can, in addition to, if somebody's going through alcohol withdrawal while they're going through acute pancreatitis, the pain related to that, it's not a good combination, right? Chronic pancreatitis. So now we've got tissue changes. The pancreas doesn't recover. The enzymes aren't being produced now, and those are seen our cells. And it's not a good situation, because now you have malabsorption occurring. You see these patients, they don't want to eat because they see food, they smell food, and they feel sick. They have pain, nausea. So now they become even more malnourished. They have the foul, frothy, fatty stools, or the steatorrhea. That's the same link to, I'm going to put the post up with all the links that I used today. I'll put it in my folder. And now we see not just changes to the acinar cells, but changes to your islets of Langerhans. So now you're watching for elevated glucoses, and this is the indication for those elevated glucoses we sometimes saw in acute pancreatitis. So an inflammatory response, as well as now in chronic changes, your islet cells just aren't functioning well. So 1/3 of the cases of patients with chronic pancreatitis end up with diabetes, type 2 diabetes, right? All right. So they start having distended abdomens with flatus. They can have cramps. They have the steatorrhea. Some of these now end up with narcotic dependence, right? Because they become opioid tolerant, and they end up really needing, can end up with a dependence and a psychological need for opioids. We see these patients returning to the ED. They're on the clock with their narcotic use. So we need to remember, about pain. And you'll hear nurses make comments, how, they are on the clock, they're drug seeking. These patients are in pain. And this is definitely one of those diagnoses where humanely you need to treat their pain, right? All right, this slide just goes over the effects of the different acute versus chronic. So you see the weight loss. You can see steatorrhea in acute, possibly, but it's more so an indication of malabsorption related to long-term effects of pancreatic enzyme insufficiency. These are more, you have your acutely ill patient. Okay. There is a procedure here, the ERC procedure, and CARE. This is a really well done video. I would recommend it. Kind of ties everything together for chronic pancreatitis. I'm not going to take time and during this to do it, but I'll make sure you have the slide with all these links. Watch this video and you'll have a good understanding of everything that you need to know for chronic pancreatitis. Okay, there's also a video on the Whipple procedure. It's out of Johns Hopkins. It's made by the professor at Johns Hopkins that's performed thousands and thousands of Whipple procedures. So you end up with chronic pancreatitis with the ERCP and these other procedures are going to prevent complications like the necrosis and so you're trying, you could use the procedures to break up stones in the pancreatic duct. You can remove them with the ERCP. You can place a stent if there's a stricture. So let's say the sphincter of Oddi is strictured. You can put a stent in there. You can surgically drain a cyst. You can divide the sphincter of Oddi and place a T-tube with these procedures. So a lot of things you can do. So I have a slide on my gallbladder lecture about T-tubes and T-tube care. And that's important. You probably see a question on the exam related to that. I'm going to close this. And I'm going to pull up, oops, I've got Kendra slides in there. Group. I'm just going to talk kind of briefly about pancreatic cancer. Okay. So the majority, I mentioned, the majority of tumors in the pancreas are in the head of the pancreas. And the pancreas lies kind of deep in the abdomen. And unfortunately, symptoms don't often occur until late. You might have painless jaundice that you notice in the sclera as the first symptom. Weight loss might be an initial symptom. So it might take you a while to, really seek medical care for that. And before you know it, it's metastasized and spread. So it does a high morbidity and a very low 5-year survival rate because of its potential for metastasis early on. It's the 4th leading cause of death in men and the 5th in women. It's rare in those less than 40. There's a higher risk for those with diabetes and those with chronic pancreatitis or family history. It can be the site of metastases or it can be primary. So about 60 to 80% occur in the head, 25% in the body and tail. And there are islet cell, you can have islet cell malignancy as well. It's 2 to 3 times more likely in smokers, so smoking is a risk factor. There are some genes, the BRCA2, LB2, that's also associated with breast cancer, can show an association.
I have a question, just a quick question. I know you're rushing to. For the pancreatic cancer, you said those are vague symptoms. Does it need to be 1 or 2 symptoms in order to diagnose with cancer, or they will just do additional tests?
Yeah, they would start with some non-invasive tests. They might do an abdominal ultrasound, right? And then if they see changes, because jaundice can be from gallbladder disease, right? If you've got stones blocking bile getting to your duodenum, if you got stone in, like I said, the common bile duct, you can see jaundice. So it could be, you're not always thinking pancreatic cancer when these symptoms do show up. But unexplained weight loss is not a good sign. They could do some screening and do an abdominal ultrasound initially, and then an abdominal CAT scan, or they might go right to the CAT scan if maybe there's a family history. So these are the different types. Don't need to know these. I just wanted to make sure you knew there are different types depending on the cell, and they hold different prognoses. So vague, once they do start having pain, it can be very vague. Another reason why it's found late. Radiation to the back, aggravated with eating, the jaundice, rapid and progressive weight loss, insulin deficiency. So as it affects the islet cells, you might start seeing elevated blood sugars, ascites. So that's a sign of metastases into the peritoneum, right? We see increased serum lipase, increased bilirubin, amylase, and then we use these in terms of diagnoses. ERCP can be used to go in and retrieve tissue sample for staging of tumor. So these are the stages. You know these stages from your oncology lectures, so I'm not going to go there, just look over the slide. These are possible treatments. So there's really no best chemotherapeutic agent, especially for metastasized pancreatic cancer, but they can use chemo, they can use radiation for palliative treatment as well, for pain management. But then they can do this Whipple procedure as well. So here's another link to that Johns Hopkins video. I think it's about 10 minutes. I would watch that as well. It will give you a really good idea of what they remove with this procedure. But what they removed is the head of the pancreas. Okay, so this would be for a tumor in the head of the pancreas. The duodenum. Okay, so you've got where the pancreas empties into the duodenum, so that's removed. You see the common bile duct, the cystic duct, and here's your gallbladder. So they remove all of that. They try to preserve the pylorus, okay? And the reason for that is dumping syndrome. So if you don't have a pyloric valve, everything just goes right through you, and you can have sudden urges to defecate related to dumping syndrome. So that pyloric valve is really important. So they do try to preserve that. If they think there could be tumor cells there, they may not preserve the pylorus, and right here they would remove, do a partial gastrectomy. Okay, so then all of this stuff gets anastomosed together. So the hepatic ducts gets anastomosed farther down to the intestine. Okay, so this is a major procedure. Patients often are very sick afterwards, and so it's a pretty extensive surgery. So discharge teaching for a patient. The patient may have a J tube, right? The duodenum's removed. You have a partial gastrectomy, but you're going to feed the jejunum to get nutrients to be absorbed in the remaining intestine. Around the clock, feedings, and then eventually cyclical, right? Just like breakfast, lunch, dinner types of cyclical feeding, and then eventually start oral diet with clear liquids and advance to solid foods, small, frequent meals. And that's pretty much, you'll see in the videos what's recommended. You saw that with malabsorption syndrome, small, frequent meals for best absorption, avoid greasy fried foods, somewhat low fiber, right? And increase it as tolerated. Okay, and then that's immediate post-op, and then long-term, you're going to follow these instructions. Pancreatic enzymes as needed. So depending on the cause, you might, if it's pancreatic cancer, you might have some viable acinar cells that are left in the pancreas that hasn't been resected. Okay. So you're going to replace insulin, you're going to replace your pancreatic enzymes as needed. Okay, so compliance with all the medications, recommendations for treatment. I talk about this slide in the voiceover. I have posted voiceover on these. If you'd like to go back and listen to more depth about each slide, they are posted on Moodle.
Denise, the voiceover wasn't working for me.
For
Really?
me either.
Oh.
Yeah,
Okay, I'll take a look at it.
I just listened to the podcast, but it's like it's a little bit different from the way the
Yeah.
PowerPoint is set up.
Yeah, usually
I
update.
actually couldn't open a couple of the voiceovers.
You could or could not,
Could not. It just
but some of
kept
them,
loading. Some of them opened up completely fine. The first one opened up fine. The second two did not open. The third one, the last one opened. So
all right, I'll check into that. Okay.
None of them work for me, so.
Okay.
Also, question on the links that for the videos that you were talking about on mine. I don't have it. Did you just recently add those?
I just actually created that this morning, and I'll post it.
Okay, thank you.
All right, let's go. So in about 20 minutes, they're going to come in do a exam review. I'm going to pull up gallbladder here real quick. I'm sorry I haven't given you guys a break. Let's just talk, about the gallbladder. Like I said, it's a storage tank, and for bile. And let's talk a little bit about bile. Your liver makes about 600 to 800 milliliters of bile per day, and the gallbladder takes that, and when it's stored there, and it concentrates that 600 to 800 to 60 to 160 milliliters. Okay, so we're talking hyperconcentration of bile. So what is in bile? Water, electrolytes, you've got all your lights, you've got some bicarb, lecithin, fatty acids, cholesterol, bilirubin, and bile salts. So the bile salts and cholesterol help break down fats in the intestine, and then they're reabsorbed into the bloodstream, returned to the liver, and then they're excreted again in bile, and that's called enterohepatic circulation. Okay, so the body uses it, and then it's returned it's absorbed into the bloodstream, returned to the liver, and then you've got this wonderful cycle that occurs. Okay, patients who so that hyperconcentrated bile can actually form stones. Okay, and then we have what's called gallstones. Okay, so we have the term cholecystitis, which is inflammation of the gallbladder. And that inflammation can be caused from several different things. Irritation from stones, which is the majority, 90%, parasitic infection, prolonged fasting associated with TPN following serious injury, okay? So somebody on long-term TPN may have what's called an acalculous cholecystitis. So it's cholecystitis from, it could be the triglycerides in the TPN, but it's acalculous, meaning no stones, no calculi, okay? Patient's gonna present with right upper quadrant pain with radiation to the right shoulder And it's going to be worsened after, so Thanksgiving Day. If you're working Friday morning in the ED, you're going to see this. Patients coming in after a fatty meal with abdominal pain, right? Upper quadrant pain, radiation to the shoulder. So anytime after a fatty meal, but they could be asymptomatic, and the elderly might present with fewer symptoms. So what happens, supersaturation with cholesterol or calcium. So this slide shows the different kinds. So here's your cholesterol stones, okay, and here's your bilirubinate stones, which are much darker, okay. So you can have a mix of these stones, and here's your gallbladder that's been excised, so it's now open, and these are all the stones that are in the gallbladder. So if you look at this slide, you can see how they can be within the gallbladder. They can be anywhere within this biliary tree, right? And you can see how they can get stuck, okay? So as pressure increases in that biliary tract, you can have these spasms of pain as these stones try to propulse to where they need to get to, right? Out of the system. So it's called biliary colic, right? So you can have colic related to kidney stones, ureteral colic. You can have colic related to your biliary system, so biliary colic, okay? These are all the risk factors. People who go on rapid weight loss diets are at increased risk of stones. When I worked in the Ornish program for reversing heart disease that I talked about in my lecture, you'd have a rapid weight loss with that program. No added fat at all. Some patients would end up having gallstones. Okay. All right, so there's a lot of different things you can do. And surgery is not always the choice. So there are different ways to manage it. So there's this one procedure called ESWL, extracorporeal outside the body shockwave lithotripsy. And you have this water bath. Patients can also be submerged actually in a bathtub, and they can use this laser to use repeated shock waves directed at the stones in the gallbladder or the common bile duct to fragment them. So once they get fragmented, then they would pass through spontaneously via the intestines. Or you could also use endoscopy to use dissolving agents. So there are two different types of dissolving agents, okay, for gallstone dissolution. And I have them in a slide further down. Let's see, where is it? I know I talk about it in my voiceover, so I'll make sure you can hear that. But there's UDCA, and then there's one other similar where you can use cholesterol dissolving agents. So these can be taken orally, they can be injected into the gallbladder to try to dissolve the stones. Okay. These are the risk factors. So when I was in nursing school, we learned fair, fat, and 40. So Caucasian, although Native Americans are also at risk for this, obesity and age, so increasing age. We also learned multiparous women. So increased number of pregnancies increase your risk of gallstones. Being treated with high-dose estrogen. Patients with cystic fibrosis are an increased risk for gallstones, and those with diabetes. So you're going to limit fat, gas-forming foods, no greater than 6 ounces of lean meat per day. So you're become aware of the symptoms that aggravate your cause aggravation of your symptoms. You're going to limit those foods. Okay? So these procedures that you can have to remove the gallstones, they're non-surgical. So they're invasive, but it's non-surgical. There's no surgical incision, so it's procedural, so endoscopic. I talked about the ERCP, where you can go in with the endoscope. It's a fiber optic scope through the esophagus. You can look at, the esophagus, the sphincters, the lower esophageal sphincter, the stomach, valves, pyloric valve, through the duodenum. And then when you get here to where the ampulla of Vater is, which is the opening that's surrounded by the sphincter of Oddi, there's a little forceps and probe that can be inputted right through the duct, okay, where the pancreatic duct of Wirsung meets the common bile duct. And if there are any stones lodged in there, and the common bile duct is an area where they commonly can lodge, you can actually go in with little baskets and retrieve the stones or the fragments from when you've had the ESWL procedure. So the stones can be retrieved through this ERCP procedure. If the sphincter needs to be dilated, it can be done here. If a stent needs to be placed within the duct or within the sphincter, it can be placed there. You can take, like I mentioned, biopsy of the cell tissue to identify and stage tumor in the pancreas. So this procedure is done for several reasons, not just for the stones, for gallstones, but the severity of acute pancreatitis, chronic pancreatitis. You can visualize pancreatic pseudocysts, so all those different things that I mentioned. And this slide just shows you how they use the baskets. Now, anytime you do something invasive, there's inflammation that can occur, right? So that's where the T-tube comes in. So if there is necrosis and a lot of drainage and inflammation, and you want to, or there's stones that may be left over that you want to be able to access and go in and retrieve later, you can place this T-tube. So I've read that T-tubes aren't used any longer. I see these year after year continue to be used in medical surgical patients. So I don't agree with that. So you've got your T-tube, it's placed in the common bile duct, and it can also be placed laparoscopically through the abdomen. So the T-tube is going to help maintain patency where you have inflammation, either from a procedure or from inflammation by disease. Okay, so it helps maintain patency. It allows a portal of entry to go in and retrieve stones. So these are all the different things. And here you have it where it's actually allowing for an opening of the stenotic sphincter. And here's a nice picture where they go in and they retrieve some stones in the common bile duct. Here's your pancreatic duct. So that T-tube, after it's been placed within the first 24 hours, typically you have about 300 to 500 mLs of biliary drainage in the first 24 hours after typical gallbladder removal surgery. And after 3 to 4 days, as that edema subsides in the common bile duct, you're going to see the amount decrease to less than 200 mLs. So monitoring the the drainage and all your tubes is important for of course for any type of tube that you have. Okay, so this is what the tubes look like if you were to see it, and this is one that's been placed through the abdominal wall. So you see it lying here in the common bile duct. Okay. So if it's placed this way, the crossbar is inserted into the common bile duct and draws the long end through an incision in the skin. So that's going to be attached to a closed gravity drainage system. You want to maintain your patient in a Fowler's position to promote gravity drainage, okay? And you're assessing for the characteristics of the bile and the amount. Always making sure that you're not obstructing flow within the bag. You keep it emptied when it becomes 3/4 of the way full. You want to make sure that it's emptied. It should not get too full. Now, bile can leak into the peritoneum. This is an invasive procedure, so you can have bleeding and hemorrhage. So you're always watching for signs of peritonitis, right? So that's kind of in your mind with any abdominal surgeries or any of these GI diagnoses. Laparoscopic cholecystectomy, we'll just spend the last few minutes talking about that, is like the standard of therapy for symptomatic gallstones, right? So you hear patients going in for what we call lap chole. Okay, so 80 to 90% of patients who are symptomatic and they're considered surgical candidates, 80 to 90% of them actually are candidates for laparoscopic. So very small percent that would require open cholecystectomy. So 4 incisions are made. They're about a 1/2 inch each in the abdomen and inserts fiber optic endoscope through the umbilical incision that allows you for visualization of the gallbladder and able to dissect and remove it. So you have your 4 different scopes. One's a retractor, one's a dissector, one's the laparoscope through the umbilical port, and then you have your operating port. What is great about the lap chole is that you can return to work within the week. You can immediately drink liquids after a lap chole, a light diet the day after, low fat. It's not going to affect peristalsis, so you don't have that risk of ileus as much as you would with a general anesthetic that would go with your open chole. And the dressings can be removed from the puncture site. Typically you have some steri strips in place and you can shower the day after the procedure. So they're going to be left open to air with the steri strips in place. Patients should report any fevers that occur. Okay. And this slide just goes over the T-tube care.
I have a question.
Post-op instructions. Yes.
Sorry, for laparoscopic, there will be less risk of bleeding though, correct? Because it's done laparoscopically?
Mm-hmm. One of the things that can happen with the laparoscope, because it's not open and you can't visually see things and move things around, they do something called insufflation of CO2 in the abdomen, and that creates protection of your organ. It decreases the risk of nicking another organ, or nicking the liver, or anything that would then increase your risk for hemorrhage and infection, right? So that insufflation of CO2 can lead to a lot of gas or flatus after the procedure, and also you can have referred pain into your shoulder, and it can be a very, very sharp, uncomfortable pain. You might have a patient, if they're not educated about this pain and what it could be, they're calling, the doctor's office or the surgeon's office saying, I've got this really, really bad pain, or they're coming in the ED. So this should be, the patient should be aware of it. They should know that it can be considered a normal side effect from the procedure, and how they can best treat it. You can use warm compresses. It's just going to take some time for that to resolve. All right, so I'm going to post the other active learning slides that I had created, and so that you can look over those. There's another case study on there as well that you can go through, and it'll help you prepare for the exam. And you want to, you do those prep you questions on this content to a mastery level of 7. And I'm available anytime. If you have questions, we can make Zoom meetings to go over anything, or you can email me with questions. I'd be glad to talk to you.
Lisa, are you gonna get those? Oh, sorry. Are you gonna get those voiceovers up today?
Yeah, I will. I have them all created. I'm not sure why a couple of them didn't work, so I will check on
None of them worked for me. I don't know why, but
Okay.
Same.
Thank you.
It allowed me to, last time I had to save them to YouTube and make links to put them on, but it allowed me to just upload them right to Moodle. So maybe that's the issue. Maybe I will create it through YouTube and do a link, and that way for sure. Okay, I'll do that.
Denise, are the prep U's due on the 17th? Is that correct?
Prep U's, ideally, all your prep U's are due. So if your exam, when's our exam? They're due before your exam content. So the idea is that they help you prepare for the exam. So any of the content for exam 4 would be due by exam 4. So that's recommended. There is a hardcore due date for all the prep U, which is I believe the day before the final, or so by midnight the day before the final. So I have you want to make sure that you're keeping up on those. If I know you have a lot on your plates, but those should help you. Ideally, you want to do them before the exam content. Okay, it sounds like some of our faculty might be coming in. So I'm going to stop sharing my screen and turn off my recorder. And I will post this on Moodle as well. Okay.